like to extend my gratefulness and thanks to Dr. Sindura for the nice hospitality. I'll be talking to a topic which is very close to my heart. So I'm basically a reproductive geneticist practicing PGTs in and out since 15 years. So we have been seeing from the morning sessions that infertility, embryology, and even fetal medicine have led to a lot of revolutionary changes which has come in, and all of them are looking at interventional treatment and management for the couple. Now, infertility is definitely on the rise. There are challenges being faced by various centers because many centers are booming up right now. And what important factor here is how are you giving the results to the patients? I mean, transparency is what matters. It's not about giving a take-home baby rate, increasing your take-home by putting multiple embryos. It's about transferring the best genetically normal embryo to have a pregnancy and then increasing the take-home baby rate. So nowadays, every patient has become smart who wants to visit a clinic where all facilities are available. So definitely there are challenges which a patient can face before pregnancy. There can be recurrent pregnancy loss or recurrent implantation failures where IVF clinics can transfer top quality blastocysts but still fail to achieve pregnancy. So if all other factors are normal, now, we as clinicians, we have ignored genetics to quite an extent, but I have seen in recent years, the genetic investigations have really picked up in our country. So it's not only abroad where PGT is practiced, I think India is slowly developing that, and we are aware of the PCPNDT rule. I have seen in one of the slides, Dr. Hitesh Bhatt has shown PGD is, PNDT has come up with a statement, use PGD only for genetic problems. So India PCPNDT Act is also not aware of what terminology has to be used. I'm sure it is never used for gender determination, but PGT is a personal choice of the patient. If you see a patient with lot of miscarriages, lot of implantation failures, do you still not give them an option of a PGT? What if they carry a genetic problem? So genetic investigations before pregnancy, there are couples who even do a premarital counseling. Nowadays, patients come to us before marriage, we want a genetic horoscope. So you should subject them to a couple carrier screening before marriage itself. So what are the elements of genetic evaluation in infertile patients? Now, I don't want to talk about very lengthy karyotyping and all. What I have observed in my experience of 15 years is in ovarian reserve, we just take AMH alone and then we decide what will be the number of oocytes retrieved and all. But then checking a fragile X is very, very mandatory. I mean, it has taken me 3 years to convince clinicians that checking a fragile X, of course, it is not for all women, but now latest research shows that the number of, it's a repeat expansion disorder. Fragile X is basically an X-linked condition where a carrier female will pass it on to the future generation. Males will be affected more. But then these bases, if present in average quantity, will also lead to pre-mutations and their generations will keep on repeating. So checking a Fragile X is very, very important as part of the AMH routine alone, which is a simple genetic test. So in the male genetic evaluation, especially for non-obstructive azoospermia cases, there are certain translocations which can be responsible, and you guys will be surprised to know that these translocations, even though the Y chromosome is not involved, the autosomal chromosomes ranging from chromosome 1 to 22, if they have a translocation, they can also impair spermatogenesis. In majority of the cases, the spermatogenesis gets impaired if there is a translocation even in males. So doing a normal karyotyping is very, very essential. Now, in your clinical practice, I'm sure you would have seen something like 22 PSTK plus, chromosome 9 QH plus. This is classified as a normal variant, but then when such couple or partners reproduce in IVF or natural pregnancy, they have more likelihood of getting a baby or more number of aneuploid embryos when you subject them to a PGTA. So counseling plays a very important role in PGTA especially, where every clinic has its own decision to perform PGTA or not. I mean, you cannot stick to a consensus saying PGTA is not for you, PGTA is only for you. It, of course, depends on the patient, the clinician, and the clinic. So these are some of the karyotypes I have put showing the normal variants, and some of them which are showing balanced translocations. So every clinician dream is to get positive pregnancy, some of the genetic culprits. Now we are aware that genetic diseases are classified into chromosomal and DNA related issues. Now you will be surprised to know that chromosomal issues, of course we know that they before 3 months of pregnancy they get aborted if they are chromosomally abnormal. So what to do for them? Of course, PGT is an answer. What to do if there are abnormalities, especially DNA related abnormalities? Such patients or couple are not subjected as infertile. They can carry a similar gene of interest and they can pass it on, especially autosomal recessive condition or X-linked condition, they can pass it on to the generation. Such couple, though they are fertile, will still require an IVF or an ICSI and a PGTM. So these are the genetic culprits which has to be tackled for a PGT. Now, I'm sure that most of us will agree that consanguinity is more in South India. So there are more chances of getting a genetically affected child. But you will be surprised to know that consanguinity doesn't matter much. Even there are people who don't get married within relations, they can carry the same gene. Out of hundreds of PGTM which we have performed, in that only 2 were consanguineously married. And the 98 couples were non-consanguineous, and they carried the same gene which was supposed to be autosomal recessive. So screening the couple for a DNA related problem is a very, very crucial component, and the recent ASRM and ACOG guidelines says that offering a clinical exome or a whole exome sequencing in such couples, and also in pan India now in all the IVF centers it is being discussed that an exome sequencing is coming up, where a patient who can spend lakhs of money for IVF, getting a carrier screening done for 20,000 rupees, not a big amount. So when you do an IVF, giving them a counseling for exome is very, very important. Because of the diversity in our country, in genetics there is nothing called rare. Any disease, every disease is rare. We are not in the US or UK that cystic fibrosis is common, this is common, hemophilia is common. It's like every disease is rare. So we cannot miss screening. And me being a reproductive geneticist, I do not believe in statistics saying 1 in 300 babies can only be affected, so I will not screen it. For me, that 1 in 300 also is not needed. I want my country's gene pool to be best. Because our country lacked that post care. When a baby is born with a genetic problem, the post care is not there. It's not like abroad. So screening is very, very essential. So clinically relevant developments in genomics and ART, you have genetic diagnosis for female infertility, male infertility, preconception expanded carrier screening. Now in carrier screening, it is mandatory that every clinic should select, depending on the type and load of genetic disease. If you want to do Fragile X, it's a different technology. If you want to do hemophilia, it's a different technology. If you want to do thalassemia, especially we have patients from Maldives coming in. In Maldives, every other couple is a carrier for alpha and beta thalassemia. So selecting a group of patients, designing on which disorder to be seen is very, very crucial. And then you have genetic testing for the voiding of anonymity of gamete donors. For centers who does donors, you can do that. Non-invasive prenatal testing, NIPT, has been talked about. PGT has been classified in different names. I'm coming to that. Even non-invasive PGT using spent media has been used, which does not require the embryo biopsy. You can test for chromosomal problems. Now, these days, polygenic risk scoring is coming up. We do not want a diabetic child. We do not want a child with cardiomyopathy. So some lifestyle modifications and diseases are there which can be looked on embryo level now, and that is called, it's a recent study in 2024 where polygenic risk scoring has been coming up in embryo level. So this is one of the report, my patients, where a carrier screening was performed. This patient came to us with an affected baby and had the classical features of Cockayne syndrome. So as per the rule, it was very essential for us to rule out whether the parents were carriers. So both parents are carriers of the ERCC8 gene here, and we are stimulating this patient for checking Cockayne syndrome in the baby, in the embryo. So this is how a carrier screening result look. I have put only this gene because the carrier screening is a full report which includes more than 200 genes. So those genes are all checked, and the ones which are pathogenic, which will cause the disease, are only reported by the company. An expanded carrier screening report for this particular case I would like to discuss. Now I am sure many clinicians would have seen a genetic exome report saying that VUS condition. VUS means variant of unknown significance, or it is not clinically significant. What do we generally do? A common people will ignore it, saying that, okay, to next pregnancy you may not get it because it's an unknown significance and PGT is not required. You can either go for an IVF and transfer the embryo without checking, or even go for a natural conception if you're conceiving. But this particular patient were carriers of HexB gene, that means a Tay-Sachs, it is a metabolic disease which was supposed to run in the family. This patient, had it been they didn't have an abnormal child earlier, even I would have said that do not undergo. But please, when you're counseling the patient, that is where a geneticist is required. A geneticist who performs the genetic counseling and does the testing has to be same. But in our country, unfortunately, genetic counselors are separate. The person who runs the technique and technology is different. But when you talk to the patient gets close to you, you know their history and you know what technique has to be employed and what type of technology. So this patient, first child was affected with Tay-Sachs. Their first child expired and they were said in another center or another hospital that you do not require, it's a VUS condition. But then when I did their carrier testing, both of them were found to be carriers of Tay-Sachs. When we did an embryo biopsy, you can see here 2 embryos are affected and 1 is inconclusive. So this patient is for a second round. So taking an important clinical reproductive decisions is very, very important when it comes to genetics. Now, what is a targeted screening? Targeted screening is a very easy approach where you know that this is the problem in one of the genes like hemophilia or thalassemia. You only look for that. So expanded carrier screening is totally different from targeted. If I am a carrier of hemophilia, I'll get myself F8 gene intron sequencing done. So this was a very straightforward case where F8 gene was sequenced and it is a pathogenic variation. It's an X-linked disease. So this was a straightforward case for PGTM. Now coming to the terminologies, I'm sure all of us are aware. A is for aneuploidy, M is for monogenic or single gene defect, SR is for balanced translocations. Now, PGTA is a very, very controversial topic in our country, especially with the PCP&DT, as I mentioned, but it depends from clinic to clinic. What we should understand is PGTA reduces the time to pregnancy and it improves the clinical outcome, especially when done on more number of embryos. Of course, it is not for all because in AM, advanced maternal age, you may not get more blastocysts. But then if you get more blastocysts or there are chances of having more aneuploidy, you can pull up the embryos and still do it. So some RIF, there are some patients, point to be noted here, recurrent implantation failure patients, majority of them do not undergo a karyotype. But 30% of the times, the karyotyping done helps us to give us an answer if they are translocation carriers. So you classify them under the PGT-SR group. I mean, you'll know a reason why all embryos are failing to implant. There might be structural deformities. As we all understand basics that chromosome has 2 arms, P and Q. There might be some segmental loss. So these are some technical things which can be a problem for RIF or RPL cases. So in such cases, PGTA helps. Now, mosaicism, I believe it is a more hyped topic. Mosaicism has slowly picked up. Mosaicism is something which is present in very small number, but I have seen many centers who report mosaicism like right and left and classify all embryos being chaotic. You know, such cases, biopsy is very, very critical. Biopsying an embryo, it depends how many cells you retrieve, how you give the laser, because laser itself is very damaging. In spite of giving laser to a different thing, if you give to a different, it might cause mitotic errors which are not real errors, and that can end up in a chaotic result. So mosaicism has to be understood very clearly. You should be smart and skilled enough to pick up mosaicism in what level is very, very important. So NGS identifies next generation sequencing. When you do a PGTA for all the chromosome, it has the capability to identify whole mosaic ploidies, segmental mosaic like P or Q arm if it is present, and few mosaics we are aware it will implant. Why does it implant? Because it has auto-correction strategy in that. So my personal thoughts on mosaicism, more than 50% of embryos are aneuploid and they go for good prognosis. Mosaicism exists in a lower percentage. It is hyped to some extent. Transfer of the mosaic embryo depends on the type of aneuploidy involved. We have a very beautiful consensus from PGDIS which has come up, and I think they have categorized which mosaics to be transferred. So I'm not going into the details. So PGTA increases take-home baby rates to 1.4 times. Finally, patients should be empowered just for few thousand. I think now PGTA rates have come down in our country to per embryo 10, 15,000. They should be empowered rather than discouraged. Giving a choice of a normal pregnancy has to be our aim with best of our abilities. Just because we know that it does not improve pregnancy rate in few does not mean we deprive our patients for a genetically healthy child. These are some of my personal concerns, what I have put in here. Benefits of NGS technology: it has high accuracy of testing. It has struggled to overcome confounding factors like mosaicism, allows preferential transfer of only euploid embryos without discarding viable mosaics, less patient dropout from each center due to failed cycles or multiple failed attempts, reduces the time to pregnancy, and in single biopsy you can do PGT M, A or SR. Why PGT is cost effective? Because we are multiplexing, we are not running a single embryo. It uses the whole genome approach. You get a full comprehensive report for all the chromosome. Millions of reads. What are reads? These are bases which are present in our DNA. So you get millions of reads against each embryo, and the comparison and the results become comparable. And of course the accuracy. So in conclusion, it is a gold standard with accurate data. I think I've already talked about it. Quantifies proportional of abnormal cells. If you biopsy around 5 to 6 cells from a blastocyst, if 1% of cell is, if 1% is mosaic, it will still define that. So based on the data, till date, PGS should no longer be considered as an experiment. I therefore believe PGT should be discussed as an option to all patients undergoing IVF, and absolutely no harm to discuss. Coming to PGT SR, when it has to be offered, I've already said in recurrent implantation failure cases, this was a case where there is a translocation between chromosome 1 and 20. So when we did a day 5 biopsy, we could find one embryo to be normal and other embryos, other two to be affected. We had an ongoing pregnancy and child was delivered. This is a data from Kraft. From 2020 to 22, where 109 couples had previous natural pregnancies, and these couples were actually, one of the partner were carrier for a balanced translocation. 92 had natural conceptions, and they had 273 pregnancies. Out of 273 pregnancies, you can see only 12 were healthy children. So imagine the rate of aneuploidy in their previous pregnancies. Some would have got biochemical pregnancy and ended up in abortion. Some would have got pregnant up to 12 weeks or 6 weeks would have got aborted. So out of 216 miscarriages, only 21 had live births and 36 had therapeutic abortions. So this is where the PGT-SR stands. So couples who have multiple times of abortion, we wait for the abortion to be 3 or 4 times, but it's nothing like that. Get a simple karyotyping done, counsel them. If they are willing, do a PGT-SR to avoid that. So for Robertsonian translocation, which involves smaller set of chromosome like 13, 14, 21, 22, etc. Also, we have data from 2013 to 22. I would like to stress here upon Robertsonian translocations are more common in males, and they actually affect spermatogenesis. So here you can see 43 couples had previous natural pregnancies, 62 had no natural pregnancies. So Robertsonian can cause more biochemical pregnancy losses, which remains unaware. Here also 6 normal KT children were born, 2 were balanced and 2 with severe malformations. So this is some of the data where after PGT-SR we had only 32% transferable embryos available. And male carriers translocation only 13%. That means they had more rates of aneuploidies. I'm just rushing through these slides. What I wanted to stress upon here is you have more aneuploid embryos for PGT-SR as well if they are carriers. So the most important point as a clinician to note here is you should test for more number of embryos depending on the type of translocation involved. If there is a reciprocal translocation present in a male, male have more sperm in numbers. You can tell them around 5 to 6 embryos are needed for testing. If it's a female, you have less eggs. So you need more number of embryos, that means around 8 to 10 for testing. So Robertsonian translocation case, NGS has helped pick us more information. Apart from 13 and 14, a 19 chromosome aneuploidy was also picked up. Point to be noted here is some laboratories use a high resolution sequencing technique. Why? Because you need to go into the depth of that chromosome. Your geneticist should decide what locus, what depth she or he has to look to classify this embryo as aneuploid or or normal embryo. So mosaicism pipeline is very, very different. It's not like a PGTA. This is something technical. PGT-SR will definitely benefit both RPL and RIF group of patients. Male translocation carriers may exhibit azoospermia, but blastocyst rate is independent of translocation involved, unlike female carriers. Mitotic errors need to be carefully analyzed. Now, when you look into your NGS data, if you're smart enough, you can actually tell the rate of aneuploidy in the future pregnancies. Suppose if a patient had all abnormal embryos, you will need to look at the data and tell whether this is mitotic error or meiotic error. So if it's a mitotic error, it will not happen in the subsequent embryo, this thing. If it's a meiotic error, it's something inherent. So your data will tell you, and dependingly, you can counsel your patient or inform your clinician that these many number of embryos are required for testing. PGTM, when to offer, it is offered for couples who are carriers for monogenic diseases. Now this is something we have started in craft 15 years back, where we use linkage analysis. Linkage is something when a couple comes to you, you have the exome report or a DNA report with you. If they are carriers, what you do is you have to take blood samples of the couple. You need blood sample of the index child. You need a blood, if the index child is not there, you need grandparent sample. Grandparent means one side of the mother and one side of the father, and they have to be tested. Now this whole scenario of testing takes around 1 or 2 months, because you need to do a pre-PGTM workup and PGTM as well. You need all these blood samples to test your embryo against that and classify whether an embryo is affected or normal or a carrier. If you do not have these blood samples, linkage analysis do not work. So any PGTM, it's an indirect way of testing, especially Huntington's chorea, Fragile X. These are indirect because this is repeat expansion disorders. You cannot classify them as abnormal or normal based on testing only the embryos. You have to have the family linkage sample. So this is how the technology works. PGTM test for a specific genetic condition prior to pregnancy. It helps couple at risk to have healthy children free from genetic disease. And even you can eliminate carriers. If you have the option of having normal embryos, you cannot transfer carriers also. And we use SNP phasing or a haplotyping method. It is very, very technical. As I mentioned in simple words, it's linkage analysis. Traditional methods of PCR and Sanger's are also available depending on the type that the geneticist can decide. TA should now, this is very important. Some centers do PGTA for PGTM and discard the aneuploid embryos and do not test for further PGTM. But discarding an embryo only after the PGT result is not ethical. So if there is a patient who requires PGTM, first do PGTM and then only which are normal, subject them for aneuploidy screening. And if no embryos are available for transfer, counsel them based on the type of aneuploidy involved. Suppose a DMD, Duchenne muscular dystrophy is there. That embryo is normal from Duchenne, DMD is not present, but it is aneuploid. So depending, will you transfer a trisomy 6 embryo? If only one normal is available, I'm sure I will counsel the patient to go ahead and transfer, though I will tell there are 80% chance it will not implant, but there might be chances it can auto-correct depending on the type of chromosome aneuploidy involved. So this is one of the breakthrough case of achondroplasia. Achondroplasia, as we know, it's a rare kind of genetic condition, not very present in India. But way back in 2016, when I recently started with craft, we had this case where this male was affected. He underwent skeletal extension. It was a very direct case. I subjected for a DNA testing. He was heterozygous for this. When we did a PGTM, we tested around 6 embryos. You can see the results here, and they have baby now. They have twins actually. Now this is a DMD, Duchenne muscular dystrophy case. We have done SNP phasing. You can look at how difficult the data comes out from embryo. I mean, this is the embryo number, this is the male, female partner, plus the plus the grandchildren, plus the embryo. So the difficult part here is the analysis, bioinformatics. Doing the testing anyone can do, but classifying the embryo as normal, abnormal, or X-linked is very, very difficult. So bioinformatics has to be very, very strong. So this was the case of DMD. We tested around 10 embryos, exon 44. Now the crucial point here is when a clinician gets a case for DMD, we just do an exome sequencing. But please beware, exome will not be able to pick up Duchenne's. You have to do a targeted approach. You have to tell them to test exon, and DMD is a very long gene. You have 78 exons present, and which exon has the mutation, it is very mandatory to test. Spinal muscular atrophy case, I'm sure most of us are aware that in our country, spinal muscular atrophy gene therapy has come in, and it really cost around 4 crores, that injection. So spinal muscular atrophy can be eliminated from the generation through PGTM instead of having that gene therapy. So for spinal muscular atrophy case, we tested around 10 embryos again through linkage analysis, and this was the result. We had nearly 6 deliveries after SMN. So crowdfunding, it came in way back 2021. Your Google will tell you the answer. The drug cost around 4 CRs. But PGTM is the need of the hour for such couples. Huntington's case, this case is very close to my heart. It was a repeat expansion disorder. Father had it. Father was a physician. His daughter had it. Daughter was not capable enough to carry out the pregnancy. So she underwent oocyte retrieval. Her mother, who was that time at the age of 45 years, she was her surrogate. So we had actually tested around 10 embryos, and you can see only 1, 2, 3 are normal. So this lady's mother was her surrogate, and she successfully delivered in the second FET. First FET, her endometrium was prepared, but estrabet somehow did not work to increase her endometrium. Second time, we did some tailor-made protocol, and then second time she had a girl baby. She is around 7 years now. Now this is a tumor cancer case where it is called as incontinentia pigmenti. This lady came to me saying she had a problem in the eye. So she was a straightforward case when I did a PGTM. But when I needed the sample from her mother, when I asked her, is your mother tested? She's like, madam, she is absolutely normal. She doesn't look like this thing. She doesn't have any symptoms. But when I tested her mother, interestingly, her mother also had this. Her sister had it. So this is not a sporadic case. Her sister had it, her mother had it. When I did the analysis using the linkage method, I found that mother also had it. So we had tested around 8 embryos. Now, another point to note here is 1 normal embryo was transferred. When we transferred around 19 weeks of anomaly scan, we found some skeletal abnormalities in the baby. So what we have to note here medico-legally is we have to counsel the patient and take a concern saying that for PGTM, we are looking only that particular disease and not more than that. So PGTA is confined to chromosomal problems. M is for this single gene defect only, where you and your husband are carriers or only you are X-linked condition. So when we did an exome sequencing on the first embryo transfer, the fetus was affected with skeletal deformity. So then we had to terminate the pregnancy, and second time we transferred a normal embryo without incontinentia. The embryo implanted, we did an amniocentesis to confirm if the skeletal problem was present or not. It was not present, and she also delivered a baby. So cycle cancellation can happen after PGT. So that is why it is very, very crucial to note from the clinician point of view how many embryos needs to be tested. Now PGTA, if not fitting for advanced maternal age whose reserve is very bad, please do not tell your patients or force them for a PGTA. Now some new modalities which has come up, I would not say new, but CRISPR is coming up. This is my next dream, where CRISPR editing on embryos, especially on zygotes, can be done to remove any genetic problem either in sperms or eggs. This news was already in focus. So now CRISPR is here to stay for the conditions where there are 2 carriers and 1 affected parent. CRISPR will stay, and where you can modify the gamete level, either egg or sperm, where both parents are affected, CRISPR can be done for healthy carriers. So there are some germline modifications for genetic disease correction. Even now you might have heard a very simple case. If a parent is a translocation carrier between chromosome 21, all babies will be Down syndrome, isn't it? So for such parents, if you do a CRISPR in egg or sperm level during the ICSI, if that gene is removed, then definitely that particular couple will have the privilege to conceive a normal baby. So such cases CRISPR can work out. So our confidence of practicing PGT in overall 11 years, our success rate is close to 95 and accuracy is close to 99. Here are some of the cases which I appreciate your time. Thanks a lot.